Now, as we talk about the placement of the balloon pump, here's a couple of chest x-rays that show us good placement of balloon pumps. As we look at the balloon itself, on a chest x-ray, the distal tip is actually made of a radio-opaque material. It's actually designed so that you can see it on an x-ray. And when we look at the black arrow in the picture in the left upper corner, that shows you the tip of the balloon pump. And then when we look at the red arrow in the picture in the right upper corner, that's another good example of the tip of the balloon. And remember again that when we're taking care of a patient, we want to make sure that that tip is sitting distal to the left subclavian. We want to make sure that it's sitting below the left subclavian so the patient has good blood flow. Now, the other things that are important to recognize about management and placement of the balloon, remember that we said we wanted to make sure that it's distal to the left subclavian. We want to make sure it's above the kidneys. The chest x-ray obviously gives us a point-in-time shot to tell us where the balloon is, but obviously that's not dynamic, and that balloon has the ability to move if the patient's moved or equipment's moved or anything else. So we always want to monitor two other things. The first thing we want to do is we want to monitor pulses in the left hand to make sure that we have good, strong pulses in our left hand continuously. An even better way to do this is actually take the patient's pulse ox and stick it on one of the fingers of their left hand. By putting their pulse ox on their left hand, you've got a continuous pleth, and that pleth will tell you that you've got continuous pulses in the left arm. If that balloon starts to migrate up, then obviously we would lose our pulse ox pleth, we would lose the perfusion to our left arm. The second way that we're going to monitor this balloon continuously to make sure that it's not in a bad place is we're also going to monitor our urinary output. Remember, when we're monitoring our urinary output, we want to use a Foley that's got a urometer on it, and we want to make sure that the patient has continuous good urinary output, at least somewhere around 30 to 50 cc's an hour for an adult. If we're starting to see a decrease in urine output, we need to ask ourselves, has the balloon migrated backwards, and is the balloon no longer sitting where it's supposed to be sitting? Now, when we talk about the balloon pump, you need to know what the big contraindications are. There's three big contraindications to putting in a balloon pump. The first big contraindication is aortic insufficiency. Remember that the way the balloon is designed is the balloon inflates. As the balloon expands, we expect that it's going to push blood backwards. If the aortic valve is incompetent, every time that balloon inflates and pushes blood backwards, some of that blood is going to be pushed right back into the left ventricle. Obviously, that's damaging to the ventricle. That actually increases the amount of failure the patient's got, and so that would not be a good thing. That would just make things worse. The other thing is, if the aortic valve is insufficient and blood is being pushed back in the left ventricle, that means less blood is being pushed down the coronary arteries, and therefore we're also losing a lot of our oxygen supply advantages of the balloon pump. The second big reason why we wouldn't put in a balloon pump is obviously if the patient has aortic disease. Obviously, a patient who's got like a aneurysm or who has some kind of dissection in their aorta or has really significant occlusive aortic disease would not be a good candidate for a balloon pump. And finally, the third contraindication to putting in a balloon pump is actually if the patient has any peripheral vascular disease. Now, this is a relative contraindication, and there's two thought processes behind this. The first one is that if the patient has peripheral vascular disease, then they probably also have severe aortic disease. The second thought process is that if they have peripheral vascular disease and their peripheral artery is already narrowed, putting a large caliber balloon through that artery can be enough that it completely occludes blood flow through the artery, and then therefore the rest of the limb would become ischemic. Which brings us to the third thing that we always want to monitor when we're monitoring a patient who's got a balloon pump. We already talked about the fact we want to put a pulse ox on the left hand so that we're monitoring their balloon placement to make sure that it's not too far up and blocking their left subclavian. We already talked about how we want to watch their urine output with the urometer to make sure that we're not blocking the renals. The third thing we want to do is we want to continuously monitor their distal pulses in whichever extremity we put the balloon in to make sure that we're not compromising blood flow to that extremity. So, like in a transport setting, a lot of times teams that do lots and lots of balloon pump transports will actually carry two pulse oxes. That way they can put one pulse ox on the toe of the extremity that the balloon went into, and they can put the other pulse ox on the patient's finger. That way they've got continuous assessment of blood flow through both extremities. Okay, now when we put in a balloon pump, obviously it's not benign, it's a horribly invasive procedure, so there are some potential complications that come with it. One of the complications that we can have is ischemia of the limb distal to the insertion site, and that's why we said it was so important that we monitor our distal pulses in whichever limb we put the balloon into. We can also dissect the aorta as we're putting in a balloon, so it's got to be done very cautiously. The other big complication that occurs a lot when we put in balloon pumps is patients actually get thrombocytopenia, which you remember thrombocytopenia is destruction of platelets, and that's because as that balloon is constantly inflating and deflating in the blood vessel, it's constantly displacing and shoving blood one direction or the other, and that obviously can be very damaging to blood. That can trigger the clotting cascade, and that can also trigger destruction of platelets. Obviously, anytime we're putting something that's the size of a garden hose up into somebody's aorta, we have the potential for the patient to get sepsis or infection, so we need to be watching for those things. We already talked about the renal complications that occur if the balloon falls too far below and blocks the renal arteries. And finally, the other thing that we could actually have potentially happen is an error of gas emboli. Now, remember that the balloon pump is actually designed so that it uses helium. The gas that moves in and out of that balloon is actually helium, and there's two reasons why we use helium. The first reason why we use helium is because helium is a very diffusible gas. So if we have a small rupture of a balloon, if we have a small tear in the balloon and helium is allowed to leak into the bloodstream, as long as it's a small tear, that's usually not a big deal because helium is very diffusible in blood and it's not going to cause big problems. But if we had a massive rupture, massive failure of the balloon, we could certainly have the potential for some amount of gas volume leakage that's enough to cause problems. Now, the other reason that we use helium is also because helium is a very small molecule, so it's very easy to shuffle back and forth. It's the fastest moving molecule, so we get a lot of advantage to using helium. We have a decreased potential for air and gas emboli, and also we can move that balloon up and down very, very quickly. Okay, now let's actually talk about timing a balloon pump. Timing a balloon pump is one of those things that people try and make really complicated when it's really not that hard. It's actually a fairly simple thing, and as long as you know the basics and you understand the physiology behind it, it's a pretty simple thing to do. Now, when we talk about the balloon pump waveform, remember that there's actually two different waveforms that we're seeing on this strip below. This strip is just an example of a strip, and actually on your balloon pump itself, there's actually going to be three waveforms. The top waveform that you see there on this strip is actually just the EKG. And remember that every balloon pump comes with an EKG, so just like you're going to put EKG leads on from your monitor, you're also going to put on the EKG leads of the balloon pump. And the EKG is really important because the most common way that we time a balloon pump is actually by timing it off of the EKG. So it's really important that the EKG leads are on, that they're placed well, and that we have a good solid EKG waveform. Now, the waveform that you see below is actually the arc line waveform. Remember we said at the very distal tip of the balloon there was actually an opening, and that opening led all the way down the lumen of the tube to an arc line setup that we put on where the red connector was at the end, or in the newer balloon pumps it's actually a fiber optic cable that actually goes directly into the balloon pump. But regardless, it's giving us an arterial waveform. It's actually giving us an aortic waveform. Now, when we talk about an aortic waveform looks just like an arc line waveform. So if you remember, when we look at an arc line waveform, remember that you have a positive upstroke, you have a downstroke with the start of diastole, and then we have the presence of a dicrotic notch as the aortic valve closes. We're going to see the exact same thing on an aortic waveform that we see on an arterial line waveform. So let's look at the waveform that we see below us here. As we time a balloon pump, one important thing you need to know about timing a balloon pump is that we can't time the balloon pump if the balloon is actually inflating and deflating with every beat of the cardiac cycle. So on the balloon pump, we have the ability to adjust what's called the assist ratio. And the assist ratio is how many times does the balloon inflate and deflate for each cardiac beat. And so we can have an assist ratio of 1:1, which means the balloon goes up and down with every cardiac beat. So cardiac beat, balloon pump inflates and deflates. Cardiac beat, balloon pumps up and down. Or we could even have a ratio of, say, like 1:2, 1:3, 1:4. So with 1:2, that would mean that for every other cardiac beat, the balloon would go up and down. In a ratio of 1:3, that would mean for every third cardiac beat, the balloon would go up and down, and obviously so on and so forth. When we're timing a balloon pump, usually we want the balloon pump to be in a ratio of 1:2. So what that means is that for every other cardiac beat, the balloon is going to inflate and deflate. So we're going to have a cardiac beat, balloon does nothing, cardiac beat, balloon inflates and deflates, cardiac beat, balloon does nothing, cardiac beat, balloon inflates and deflates. And that's exactly what we see on this strip here below us. When we look at this strip here, we see that we've got, starting on the very left side of the strip, you have an aortic beat, and then on the aortic beat, as the pressure starts to come down, you have a spike up. That's the inflation of the balloon. As that spike up decreases, we have a plateau. That's the balloon maintaining its pressure. And then you'll notice that the balloon drops its pressure, and we have a nice deep waveform as we start the next cardiac beat. So with the next cardiac beat, we have systole, we go into a dicrotic notch, and we have a rest where nothing happens. So this is a balloon that's being timed at a 1-to-2 ratio right now. So the balloon is inflating 1 time for every 2 cardiac beats. And that's exactly where we need it for timing. Okay, so let's talk about timing. When we talk about timing, remember we said that we want the balloon to inflate right as the heart starts to rest. So right as the heart finishes its systole, right as it starts to relax, that's when we want the balloon to inflate. Well, that corresponds with when we typically see a dicrotic notch. So when we talk about inflation, we actually want the balloon to inflate right on the dicrotic notch. And so the way we know the balloon is inflating right on the dicrotic notch is we look for the presence of a nice tight V, like the letter V is in Victor. We want to see a nice tight V right on the dicrotic notch. Now, when we see that nice tight V, the way we know it's right on the dicrotic notch is we look at the dicrotic notches on either side. Because remember, the beats on either side are going to be unassisted because we're in a 1-to-2 ratio. If the tip of that V is sitting right in line with the dicrotic notches on the other 2 beats, then that is perfect. That is a perfect inflation time. That is what we want to see. Nice, tight, sharp V right on the dicrotic notch. Now, we want the balloon to hold its pressure, and then we want the balloon to deflate right before the next cardiac beat. And remember, we said the big advantage we get from deflation is that there's a decrease in systemic vascular resistance that makes it easier for the heart to push out blood. The way we judge to make sure we have good deflation is we look for a nice, deep, symmetrical U. U is in uniform. So remember, on the inflation side, we are looking for a nice, tight V as in Victor, and we wanted to see that right on the dicrotic notch. On the deflation side, we're looking for a nice, round, symmetrical U, and we want to see that right before the next beat, and we want to see, really important, that that U is symmetrical. If we have a U that's not symmetrical, for instance, if it's nice and round and comes down, and then there's like a trailing off before the next beat, then it's deflating too early and we're losing some of that decrease in systemic vascular resistance. So let's look at a couple of inflation or deflation problems that we can have. The first type of timing error that we can have is we can actually have a problem with early inflation. So remember, with early inflation, the balloon, what's happening is the balloon is popping up before the heart has even finished its contraction cycle. So as the heart is trying to push blood up, as it's trying to squeeze down in the aorta, boom, the balloon comes up. So basically the heart is trying to push blood up against a cork. This is dangerous. This is a very dangerous thing. This is a very bad thing. So how do we tell if we have early inflation? Well, remember, with inflation, we said what we were looking for was a nice tight V, but we wanted to see it right on the tip of the dicrotic notch. When we look at the waveform below, you see a nice tight V, but when we look at where the dicrotic notches are around it, that V tip is way above the line. So this is early inflation. And remember, early inflation is dangerous. We need to move this inflation back. We would need to slide our little inflation knob back so that the patient is actually got the tip of the V occurring right on the dicrotic notches. This is a good example right here of early inflation. And so, again, remember, early inflation is dangerous. Now let's look at late inflation. So when we look at this example right here, this is a good example of late inflation. With late inflation, the big thing that we lose is we lose the nice tight V. So what that means is we've got the aortic wave comes up, we've got the presence of a dicrotic notch, and then the balloon comes up. Well, what's the problem with late inflation? Well, the problem with late inflation is if the balloon if the balloon inflates too late, well, most of the blood has already passed by it, so we don't get a big amount of help. Now, when we talk about late inflation, the big thing you remember about late inflation is it's not dangerous. Late inflation is not dangerous, it's just not optimal. And what's really important with the timing errors is that you know what's dangerous and what's just not optimal. Remember we said early inflation was dangerous because the heart was basically trying to push blood up against a cork. Late inflation is not dangerous, it's just not optimal. And so what we would want to do for this patient is we would want to move their inflation back just a little bit so that we actually had a nice tight V that was occurring right on the dicrotic notch. Now let's look at the deflation side of things. Remember with deflation, the whole thing that deflation does for us is it decreases systemic vascular resistance and makes it easier for that heart to push blood out. When we talk about deflation, we can also have early or late deflation. Let's talk first about early deflation. Early deflation is where the balloon comes down too early. So heart beats, balloon inflates, heart goes into relaxation, balloon comes down, and then the heart beats. Well, if we have the balloon come down too early, we lose that suck that we would get with the balloon coming down right as the heart starts to contract. So early deflation is another example of a timing error that's not dangerous, but it's just not helpful. It's just not optimal. So what we would want to do is we would want to move this patient's deflation over. And remember, the big thing we're looking for with deflation is we're looking for a nice round symmetrical U. When we look at this patient's deflation waveform, it's not nice and round. We've actually got a decrease and then we have this gradual return to baseline. It's not symmetrical and it's not round. So this is early deflation. Finally, the last type of deflation that we can have is we can have late deflation. And late deflation, just like early inflation, is dangerous. When we look at this patient's waveform, when we look at the deflation side of things, we don't see a nice round symmetrical U. Instead, we see a waveform that looks a lot more like a V. That's dangerous. What that means to us is that the heart is already starting to contract and push blood out before the balloon pump is even deflated. So again, we've got the same issues with early inflation. We have a heart that's trying to contract against a cork. So that obviously is very damaging and very taxing to the myocardium, so that's dangerous and that needs to be fixed. Now when we look at this waveform here, the late deflation is circled there. You see that it's a V instead of a nice round symmetrical U. We would want to move this back, but also if you look at this waveform is actually problematic in two ways. This patient has both early inflation and late deflation. So this waveform would be a very dangerous waveform. We would have to do something about this. We would need to move our inflation back just a little bit till our dicrotic notch till our V is right on the dicrotic notch, and we would have to move our our deflation back just a little bit to where we've got a nice deep symmetrical U. Now remember that if you're at a point where you're trying to figure out what's dangerous and what's not dangerous, remember that between each set of cardiac cycles, so between each aortic waveform here and aortic waveform here, going towards the middle is never going to be dangerous. So in other words, moving our inflation time to later or moving our deflation time to earlier is not going to be dangerous. It's just not going to be optimal. What we're more concerned about is if the inflation time is too early and thus interferes with the previous cardiac cycle, or if the deflation time is too late and thus interferes with the next cardiac cycle. Those are the two things we really care about. And again, the way we identify early inflation is a tight V that's above the dicrotic notch, and on the deflation side, it's the lack of a nice round symmetrical U. It's more of a V shape instead of a U shape. Again, those two things need to be dealt with. Okay, so when we look at this waveform here, what do we see? So when we look at this patient's inflation, how does their inflation look? Well, remember with inflation, we said the big thing that we were looking for was a nice tight V. We're looking for a nice tight V to occur right on the dicrotic notch. And when we look at this patient's waveform, we see that there's aortic beat, then there's a dicrotic notch, then there's inflation. So we know that this patient has this patient has late inflation. So is this dangerous or just not optimal? This is a good example of something that's just not optimal. This patient's inflation is just not optimal. It's not dangerous, but it's just not optimal. Now let's look at the deflation side, because remember we have to look at each side independently. When we look at the deflation side, we said we were looking for a nice round symmetrical U, and we see that we do have a nice round symmetrical U, so this patient's deflation looks really, really good. So this patient's whole problem is this patient has an early or excuse me, I keep saying early, this patient has a late inflation. This balloon pump waveform that you see in front of you is not a dangerous waveform. It could just be made a little more optimal if we would actually just move our inflation just a little bit earlier to where we had that nice tight V. Now what about when we look at this waveform right here? When we look at this waveform, is this waveform dangerous or just not optimal? Well, this waveform is a good example of a dangerous waveform. When we look at this waveform, this is a waveform that has to be addressed. This is dangerous. When we look at this patient's inflation, remember on inflation we want to see a nice tight V, but we want to see the tip of it is right at the dicrotic notch. And if we look at the dicrotic notches around it, we see that this inflation is way too early. This inflation is dangerous. This is early inflation. It needs to be addressed. Now what about the deflation side? Well, when we look at the deflation side, remember we said we're looking for a nice round symmetrical U. And when we look at this patient's waveform, we don't see a nice round symmetrical U, we see more of a V-type shape. So this patient's deflation is late, right? This patient has late deflation. So is this dangerous or just not optimal? This is also dangerous. Remember we said that early inflation or late deflation were dangerous. So this patient has both an early inflation and a late deflation. This is a very dangerous waveform. This needs to be addressed. We need to move the inflation back a little bit. We need to make it a little bit later to where the V is right on the dicrotic notch. And when we look at the deflation, we need to move the deflation a little bit earlier to where we've got a nice round symmetrical U. Now what about when we look at this waveform? Well, when we look at this waveform, we see that we've got balloon inflation that occurs after the dicrotic notch. So we don't have a nice tight V. So is this dangerous or just not optimal? This is just not optimal. This is late inflation. And remember we said late inflation is not dangerous, it's just not optimal. Now what about when we look at the other side? What about when we look at the deflation side? Remember for deflation what we were looking for was a nice round symmetrical U, and obviously when we look at this deflation we do not see that. This is not a nice round symmetrical U. We have a gradual return back to baseline, so this is early deflation. So this patient, this balloon pump strip that we're looking at in front of us is a patient who is having late inflation and early deflation. Is this a dangerous waveform or just not optimal? Well, we know that this is just not optimal. We know that we need to improve this a little bit. So what we would want to do for this patient is we would want to move their inflation a little bit earlier to where we have a nice tight V on the dicrotic notch, and we would want to move their deflation just a little bit later to where we've got a nice round symmetrical U. Okay, let's look at one more here. When we look at this one here, when we look at the inflation, how does the inflation look? Our inflation actually doesn't look too bad. We've got a nice tight V. That nice tight V is pretty close to where the dicrotic notch is, so this inflation probably is pretty good. What about when we look at this patient's deflation? Well, remember with deflation, we're looking for a nice round symmetrical U, and that we don't have. We've got a gradual return back to baseline, so this is another example of a patient who has got early deflation. So is this dangerous or just not optimal? Remember we said with early deflation it's just not optimal. So what we would want to do is we would want to move this patient's deflation a little bit later to where we've got a nice round U, but this is not a dangerous waveform. It's just something that needs to be augmented and made to look a little bit better. Okay, now what about if you're actually transporting somebody who's got a balloon pump? Well, there are a couple of things about balloon pumps that are specific to transport that we need to know about. Remember that when we're transporting a patient, whether it's by ground or by air, we tend to have a lot more patient vibration than we do when a patient's sitting in a nice stable bed in the hospital. So we may actually have to change the trigger mode. Usually we trigger the balloon pump off of the EKG. It's designed to inflate off of the EKG, but if we're having lots of problems with the EKG, we may actually have to change it to a different trigger mode, and we've got several choices. Probably the most common one that we would change it to is actually change it to the arterial or the pressure mode, where it would actually trigger off the art line directly. Now remember that the balloon pump is also designed so that when there's changes in the pressure in the balloon, it purges. So what does purging mean? Well, remember that when we actually take a balloon pump and we turn it on, what the balloon's going to do is it's going to suck, what the pump's going to do is it's going to suck helium out of a helium tank into an intermediary chamber, if you will. And that amount of helium is actually going to be what shoots back and forth between the balloon and the intermediate chamber. When the balloon pump senses that there's a change in pressure, it purges, and when it purges, what that means is it dumps out all the helium that was in the intermediate chamber, and then it sucks more helium from the tank into that intermediary chamber. Well, if we've got a change in pressure because of a change in altitude or because of a change in barometric pressure, the balloon is going to purge. And when it purges, it usually takes a couple minutes to do that. So usually what we'll see is that the balloon is going to stop pumping while it purges. You'll see an alarm that says it's purging, and then when it's done purging, it'll go right back into its cycle. We just want to watch the patient during that time to make sure that they're okay. Now, some other things to think about. Remember that if you're using one of the older balloon pumps that actually required an ART line, we want to make sure that all the air is out of the ART line before we start transport, because when we take the patient up to altitude, a little bit of air is going to become a lot of air, and so we could have problems with the ART line waveform itself. That's important because we're going to time off of the ART line, so we want to make sure that, that the ART line is working patently. Now, what happens if the patient goes into cardiac arrest? If the patient goes into cardiac arrest, one of the things that we want to do is we want to actually turn the balloon pump to where it's on arterial trigger or internal trigger. What that's designed to do is when we give compressions, the balloon is actually going to time off of arterial pulsations instead of off of the EKG. So again, if the patient goes into cardiac arrest, we're going to do CPR just like we would normally do it, but the one thing we want to do with the balloon is we want to turn it to internal trigger or to arterial pressure trigger. Now, what if the balloon pump just fails? What if the balloon pump just stops and we can't get it to work at all, but we've still got a balloon in the body? Well, remember that if we have a power failure, we actually need to manually cycle the balloon. And the balloon, when it comes in the package, it also comes with a syringe. That syringe is designed so that it holds the same amount of air that the balloon holds. What we want to do if the balloon fails and we don't have the ability to inflate and deflate the balloon with the pump is we want to take that syringe and attach it to our balloon pump tubing, and then what we're going to do is we're going to manually inflate and deflate the balloon. Now, when we do that, we want to do that at least every 15 minutes. There was an FDA recall or an FDA alert that came out last year that said that when patients have a balloon sitting in for more than 15 minutes, it actually increases the chances that they're going to die. There have been a couple of case deaths where balloons were left sitting in the body for prolonged periods of time, and we know that the big problem is if the balloon's sitting doing nothing, blood is going to coagulate on it, and then we're going to end up with clotting problems, which are going to be magnified when we go to try to pull the balloon out through its sheath and we shower all that emboli. So we want to make sure that if the balloon is stagnant, that we're manually inflating it with the syringe at least every 15 minutes. Now, that brings up an important point. Make sure that the syringe for that balloon goes with that balloon if the patient is being transferred. Now, some other things to think about from a transport perspective. You want to make sure that we've always got plenty of helium available to us. Remember that if the balloon pump runs out of helium, the balloon's not going to work, so we want to make sure there's plenty of helium. Remember that when we go up and down in altitude, we're going to purge a lot more than we would sitting in the hospital. So especially if we're leaving the facility, we certainly want to have extra helium with us. Some other transport considerations. Remember that before you take the patient, you want to make sure the balloon is sitting where it's supposed to. So ideally, we would like to get a chest x-ray to verify placement. The other thing is we want to make sure that the distal tip is sitting below the aortic below the aortic arch. And we also want to make sure that the proximal end of the balloon is sitting above the renal arteries. Remember, we want to make sure the patient has a Foley in transport so we can watch their urinary output, and we also want pulse oxes ideally on the left hand and on whichever leg we've stuck the balloon in so that we can also monitor distal pulses continuously in transport. Okay, so enough about balloon pumps. Now let's talk about a couple of other palliative things real quick before we break. Let's talk for just a few minutes about ventricular assist devices. There's several different types of ventricular assist devices out there made by various manufacturers, but what they all have in common is the way they work is they actually plug into the ventricle, whether it's a RVAD being a right ventricular assist device or an LVAD being a left ventricular assist device, and what they're going to do is they're going to provide some kind of mechanical pumping of blood. Now, we actually have three different choices of ventricular assist devices. We already talked about the RVAD being the right ventricular assist device and the LVAD being the left ventricular assist device. The other assist device that we can actually use is we can use a BiVAD, which does both. Now, typically, if we're putting in an RVAD, they make a hole into the right ventricle, they attach the VAD into the right ventricle, and then they're going to attach the other end of the VAD where the blood comes out into the pulmonary artery. With a LVAD, what we're going to do is make a hole in the left ventricle, and we're going to attach the LVAD there, and then as blood goes through the pump, it's going to be pumped out through tubing that has been attached into the aorta. So what are the indications for putting in a VAD? Well, we basically have three big reasons why we would stick a VAD in somebody. The first reason why we might stick a VAD in somebody is as a bridge to transplantation. We have a patient who's got a really, really bad heart, so bad that they need a heart transplant, but we've got to put them on a waiting list to get them a heart. A lot of times we'll put VADs in this case, and these patients a lot of times will even go home on their VADs. Another place where we might put a VAD in is we might put it in somebody who's having thoracic aortic surgery when they've got a high aortic cross clamp, and we want to bypass that. So for instance, if we've got a cross clamp the aorta really, really high up, then what we may do is we may actually put in a VAD to circumvent our cross clamp. The third place where we might put a VAD in is in the patient who's a post-cardiotomy patient who's got cardiogenic shock despite the fact we've already put in a balloon pump and they're not doing well. So for instance, the patient has a CABG, we stick a balloon pump in them, they're still not doing well, and we want to augment their circulation, so we'll go ahead and stick in a VAD. Okay, now when we talk about VADs, some generalizations about taking care of a patient who's got a VAD. The first thing to remember about VADs is that they're preload dependent. The patient has to have an adequate amount of preload. If the patient doesn't have adequate preload, the VAD's not going to work. They all work by various mechanisms, but they all do the same thing in that they pump. And in order for a pump to work, it's got to have adequate pre-pressure. And in people, obviously, we call that preload. So we want to make sure the patient has plenty of preload. The second thing is that when we put a VAD in, remember that we have to anticoagulate the patient so that they don't clot around the VAD. And the way that we assure that they've been adequately coagulated is we actually follow something called the ACT, or the activated clotting time. And as a general rule, most of the time when a patient's got a VAD in, we want their ACT to be at least 150. Now, once we've put a BiVAD in, if we've put a BiVAD in, a lot of times we can actually stop our inotropes because the BiVAD will do a lot of the work, and so we don't need to give the patient inotropes anymore. If the patient has an internal VAD, like in the previous picture and this picture, these are HeartMate 1 and 2s, these patients can actually go home because the VAD is actually implanted into their chest. One thing you do want to know about a patient who's got a VAD, if you're taking care of them, is whether or not they are a candidate for CPR. It depends on the VAD as to whether or not a patient can have CPR. With some VADs, you do CPR just like you would do it for anybody else if the patient goes into cardiac arrest. And with other VADs, you don't do CPR if the patient's got a VAD. Instead, what you do is you pump the VAD. Now, if you don't know, if you're not familiar, if you're going to be taking care of a VAD and it's new VAD that you're not familiar with, the patients, before they're allowed to go home on a VAD, they have a tremendous amount of education about what the VAD is, what it does, how it works, and a lot of times they can answer your questions. If you're not sure, or if they're not sure, the other thing that they should be carrying with them all the time is they should be carrying a backup bag that has several things in it, like it's got extra VAD batteries and all that kind of good stuff. But in that VAD bag, there should also be a contact information for a clinical nurse specialist who is following that patient, and usually that number is like an 800 number, and that number goes to a pager or goes to somebody who's available 24 hours a day, just there for the clinician to be able, or for the person taking care of the patient to be able to call that nurse clinician for advice about what to do with the VAD. So if you're not sure about it, if you think that it's malfunctioning or you don't know what's going on, then ask the patient for that card and call that clinician so that they can guide you through what you need to do with the VAD. Now, what are the complications to putting in a VAD? Well, remember that in order to put in a VAD, we said we had to anticoagulate the patient. So especially if we've just put in a VAD, one of the big things that we're concerned about is uncontrolled bleeding. When we put in a VAD, we have to make a huge hole in the ventricle. So it's not unheard of for patients to bleed after a VAD. So we want to make sure that we're really controlling their bleeding. We want to make sure we're watching really closely to make sure they don't have excessive drainage from their chest. A lot of times when they first have the VAD put in, they'll have chest tubes. We want to make sure that we're watching those chest tubes for excessive bleeding. We want to make sure we're watching for things like a tamponade, and we also want to make sure that if the patient is bleeding, that we're correctly managing the fluid loss. Now, another complication that we can have is if the patient is inadequately coagulated, they may actually start to get thrombi and emboli, and it can be enough that it can actually block the actual channels of the VAD. If that occurs, then the patient may actually need an increase in their clotting, a decrease in their clotting in the form of anticoagulation. And if it's bad enough, we may actually have to do some kind of surgical intervention to maintain the patency of that VAD. Now, because patients who have BADs are critically ill, it's not uncommon for these patients to get multi-organ dysfunction syndrome, so we certainly want to be watching for things like SIRS and sepsis. And again, we want to be watching for pump flow problems. Remember that with pump flow problems, they usually result from one of four things. It's either because the patient's right ventricle is failing, if the patient's only got an LVAD. We remember again that patients with LVADs are very volume dependent. We already talked about the cannula obstruction. And the other thing that can cause a pump flow problem is if the patient gets pulmonary hypertension. And remember, the main reason why somebody would get pulmonary hypertension is because they're hypoxic. So we want to make sure that patients who have a VAD are also not hypoxic. Now, what about if you're transporting somebody who's got a VAD? Well, again, remember, if you're not familiar with a VAD, you need to speak with the rep or the nurse clinician before you assume care. The second thing that you want to do is you want to make sure that you have the ability to actually secure the VAD in the aircraft. Now, if the patient's got one of the little tiny VADs like a HeartMate 1 or 2, then obviously you're not going to have a bunch of equipment because all the equipment is on them. But if we're transporting somebody who's got one of the older type of VADs, we may actually have a fairly large console that needs to go with us. Now, the other thing that you want to know about if you're going to be transporting a patient who's got a VAD is if the VAD has external bladders. If the VAD has external bladders, remember that those bladders have to sit, depending on whether it's depending on the manufacturer, somewhere between 6 and 34 inches off the floor. This is a big concern for us in the aircraft because a lot of times we don't have 6 inches of clearance. So in order to be able to transport a patient who's got a VAD in place, we need to make sure that we have the ability to get the stretcher up high enough that the bladders have the ability to be dependent. And lastly, one other big transport consideration with the VAD is that most of your ventricular assist devices that have a big external pump require 280 watts of electricity, and so we want to make sure that we have an inverter that's powerful enough that it can run the VAD. Okay, let's wrap up by just talking about ECMO for just a few minutes. Remember that ECMO is extracorporeal membrane oxygenation, and essentially ECMO is a type of cardiac bypass. So when would we put somebody on ECMO? Well, it's pretty simple. The reason why people go on ECMO is because they have failed everything else. And so we use it to augment the heart, the lungs, or both. Now, when we talk about the way that ECMO works, we're actually going to suck blood out of the body, we're going to pump it through a pump, and then that pump is actually going to move it through an oxygen filtration device where we're actually going to infuse oxygen into the blood. As the blood circuit continues on, that blood is heated because it loses temperatures and moves outside the body, and then it's moved back into the body. There's a couple ways that we can do this. One of the ways that we can do this is we can actually do venous-venous cannulation. And when we do veno-venous cannulation, we actually have two cannulas that are actually pulling blood out of the venous system and putting it back into the venous system. The other way that we can do this is we can actually do this with veno-arterial cannulation, which is where we would have one cannula that's sitting in the artery, that's what's sucking blood out, and then we have another artery that's sitting in the vein that's replacing it. Now, remember that when we talk about ECMO, ECMO is gravity dependent. The blood that is moved from the body is actually moved under gravity. So we want to make sure that, again, if we're taking care of these patients, that they're up high enough that there's enough dependency for blood to be able to drain out of the body. Now, when we talk about blood passage, remember again that it's going to go first through a bladder. As it goes through the bladder, it then moves through a pump, moves through a membrane oxygenator, and then it obviously moves through a heat exchanger. Now, that's just a very basic ECMO circuit. We can actually take them and make them much more complicated. Some of the ECMO circuits that we use, we can actually add things to it like continuous renal replacement therapy. We can infuse drugs through the circuit. So there can be more pieces to ECMO than just these four pieces. Now, when we talk about treating the patient or taking care of the patient who's got ECMO, our goal here is certainly not to make you an ECMO technician. That takes lots and lots of training, but just some general things that you need to know about. First, you need to know that these patients are very logistically complicated. Remember that the whole reason they're on ECMO is because they have failed everything else. So just the patient in and of themselves is critically ill. And then when we add in all the technologic pieces that go with ECMO, it makes it even more complicated. Remember that because we're moving blood from the body and moving it through the ECMO circuit, these patients are very susceptible to hypothermia. So we want to make sure that we're adequately warming these patients. The other thing is we're moving blood through the circuit, we're exposing blood to synthetic materials that are not blood vessels, and so that tends to activate the patient's clotting cascade. So in order to prevent them from clotting and from forming a bunch of thrombi, the other thing that we do for these patients is we anticoagulate them, usually with heparin or something like that. Now that's obviously a big concern because we have a huge amount of blood that's being moved outside the body, and we're anticoagulating all of it. So if we have damage to the circuit, or if we have leakage somewhere, it's very, very easy for these patients to bleed to death. So we want to be super vigilant about watching to make sure that that we're making sure there's not any insidious blood loss or frank blood loss anywhere. Now, the last thing that you need to know about the oxygenator itself is, remember that the oxygenator is a filter, and so as blood moves through that filter, it filters lots of things, and one of the things that it filters is some medications. So if you're putting a patient on ECMO, we want to look at our doses of our medications and make sure that they're still therapeutic. Oftentimes when people are on ECMO, we actually have to put them on a higher doses of meds to make sure that they're still getting the therapeutic effect. Okay, that's our discussion of palliative cardiac equipment. If you have any questions, feel free to contact me. Again, my name is Anthony Baca, and my email address is abaca@camanagement.org. That's abaca@camanagement.org. Or you can find contact information on our website, which is www.camanagement.org. That's www.camanagement, as in clinical analysis, management.org. In the interim, thanks, and I hope that you have a great day.
Come for you.